Hi guys, welcome to your lecture on Individual Module 3, Grief and Loss, and specifically Perinatal Loss and Children's Response to Loss. Here are your learning outcomes for both perinatal loss and children's response to loss, same as in your syllabus and same as in your book. And we're going to first talk about anticipatory grief. This is a concept that you probably have heard of and probably gone over in some of your previous courses, but this is grief that is experienced before the event actually happens to that person. So, for example, someone whose mother is dying of cancer and they have a 6-month time frame to live. They go through something called anticipatory grief. It's a grieving process that happens before the death occurs. So think of it in that sort of framework. But along the lines of that, there is no evidence that actually proves that anticipatory grief will lessen the actual grief process once that crisis occurs to that person. So keep that in mind. People can have anticipatory grief, but it doesn't mean that it's going to lessen the grief that they feel or the stages that they go through post occurrence of that event. So a quick review on Kubler-Ross. Remember, Kubler-Ross is the theory that explores the 5 different stages of grief, and those are denial, anger, bargaining, depression, and acceptance. And it was originally thought that these stages of grief occurred in order. But there has been much debate as to whether or not that is actually the case. Um, the it is theorized now that these stages do not occur in this order necessarily. They may or they may not. It can depend on the developmental level of the person who is experiencing the grief. It can depend on their past experiences. So keep that in mind. Let's move on to perinatal loss, and that's what we're going to discuss first. So to understand perinatal loss, you have to understand what the perinatal period is. And the perinatal period would be anything from conception until the actual birth of the newborn. So keep that in mind. This is the pregnancy itself. So what causes perinatal loss? These are possible reasons that can cause perinatal loss, and we've divided them into 2 categories. There could be fetal reasons and there can be maternal reasons, and there are risk factors in both categories. So let's focus on fetal for a minute. So some things that can happen with the fetus that possibly might cause perinatal loss would be genetic abnormalities, chromosomal abnormalities, congenital malformations like maybe a baby who has developed normally but has no brain. Maybe it's a congenital heart defect that is unsurvivable. It can happen from acquired infections that happen through mom. You know, we just had our immunology lecture where we talked about immunizations, and we know that the fetus gets passive immunity through the mother. Well, if antibodies from a mom can transfer through the placenta to protect the baby, also infections can do the same thing. So here you might think of things like toxoplasmosis, and that's something that mothers can get from cat litter. That's why if you've ever had a significant other or you yourself have ever been pregnant and been to the doctor, they always ask you, it's a question on normally the questionnaires you get right at the beginning of your prenatal care, do you have cats in the home? And this is why they ask you that. Multiple gestation. Whenever we have a pregnancy that is comprised of more than one fetus, there are times when um, one fetus can actually take more um, reserve, more energy, more nutrition from mom than the other one gets. And sometimes the result of that can be an intrauterine fetal demise or an IUFD. So, multiple gestation puts people at risk for perinatal loss. Exposure to teratogens. And teratogens are something in the environment that could be potentially harmful to a fetus. And then oftentimes, the reason is unknown and we just can't determine. So, moving over to maternal causes for perinatal loss. Chronic disease such as diabetes, hypertension, hormonal issues, maternal infections such as STDs, moms who are older, substance abuse and physical violence, complications of pregnancies, complications from diagnostic testing, uterine abnormalities, and then again, unknown causes. And many of these different things we will talk about throughout the course. So you'll learn in more detail how these things can cause perinatal loss. So, what about some risk factors? Well, if mom is over 40 years old, that puts her at risk for perinatal loss. If she's had a previous history of miscarriages or a previous history of an intrauterine fetal demise, that puts her at a greater risk. If she has past instances where she's had multiple complications related to miscarriages or abortions, and that term can be used interchangeably. So, um, if I say abortion, I may be talking about a miscarriage and not necessarily a surgical abortion. An incompetent cervix, and this is just um, a thing that happens to some women in which the baby becomes heavy in the uterus, or as it starts to grow and it becomes heavy, it presses down on the cervix and the cervix starts to open. It, for some reason, will not hold the weight of a growing fetus. And then you have an early delivery. Normally, it happens prior to that fetus's viability. So, incompetent cervix is also a risk factor. Um, Diabetes and thyroid disease, substance abusers are at a great risk for perinatal loss. And then there you see again exposure to teratogens. So, the big thing with perinatal loss is prevention. And oftentimes it is very difficult to prevent a perinatal loss because you don't know that someone is at risk, or you don't know that it's going to happen to someone until it's already occurred. So, for example, the woman with an incompetent cervix, um, being pregnant for the first time, she would have no idea that she has an incompetent cervix until um, it presents itself, and she goes to the hospital, and oftentimes it's irreversible. There's nothing you can do about it. Sometimes there is, but oftentimes there's not. However, in subsequent pregnancies after that first loss, that mother knows she is at risk and knows that she has a history of incompetent cervix, and there are things that can be done early on in pregnancy to prevent loss of subsequent pregnancies. Um, we really have to focus on health promotion teaching so we can help lessen the risk for perinatal loss. And that is why it is so important for individuals to seek early prenatal care and even begin seeking care prior to becoming pregnant. Just when they're even thinking about it, they need to be consulting with a doctor, um, talking with nurses, and learning about things that can prevent perinatal loss or an unsuccessful pregnancy. So, what would be some nursing assessments in regards to perinatal loss? Well, if you have a mom who comes in with an intrauterine fetal demise, the IUFD, then part of what we assess is fetal movement. A big sign that a mom can be at risk for IUFD is if the fetus has had a significant decrease or a complete loss of fetal movement. And this is a subjective assessment. This has to be reported to the nurse by mom. And an IUFD only occurs if the fetus is greater than or equal to 20 weeks gestation. Anything less than 20 weeks, so 19 weeks and less, would be considered an abortion or a miscarriage. And the reason for that is because at the age of 20 weeks, that's what we consider the point of viability for a fetus. So, in general, it is accepted that at 20 weeks, we can normally save a baby and help it to live. We can do interventions that will help it grow and live. So, anything greater than 20 weeks or equal to 20 weeks would be considered an intrauterine fetal demise. If this happens, there's a loss of the fetal heart rate. It's diagnosed with an ultrasound, and you do an ultrasound and you actually look to see if the heart chambers are moving or not. And there are some preliminary signs and symptoms that we might see, and those include vaginal bleeding that is painless, and it can be very mild to very excessive, or there may be some mild to severe abdominal pain, not always. The biggest indicator that something is not right with a pregnancy is when the mom reports to you that there is a loss of fetal movement or that the baby is not moving like it normally does. That should send a red flag up immediately to any L&D nurse or obstetric nurse. So obstetrically, how do we intervene if this happens? Well, and a lot of the times these people go through a spontaneous labor and delivery process. They may have to have a dilatation and curettage or a D&C for incomplete abortions, meaning there are fetal parts that are left in the uterine cavity, and those have to come out. So sometimes the doctor has to take the patient down to the OR and actually scrape out the contents of the uterus and the lining, and that's called a D&C. Sometimes we have to do a C-section after the baby is already dead, especially if the mom is a previous C-section. And sometimes we actually have to induce labor. And if that happens, then we give a prostaglandin agent to help the cervix efface and dilate or open up. And then we may have to put mom on a Pitocin drip to help her have contractions to expel the fetus. So things to watch for would be hemorrhage, infections, fluid and electrolyte imbalances, and postpartum depression. Um, this is a really sad thing to have to take care of, and it requires um, the nurse to be knowledgeable about perinatal loss, about how families may or may not react, and um, it's just important to be really socially connected and have a good rapport with your patient and their families. Here's a list of some other interventions that can be done, and I'll let you read about these in your book and look these up. The Betke-Kleinhauer test you see listed third there is a test that determines um, whether the mom and the baby's blood are Rh compatible, just so you know. So grieving a perinatal loss. Well, what should we expect as nurses? No two will ever be the same. It's a very individualized process for parents and mothers. Postpartum depression can occur. So just because the mom did not have a living child does not mean that she cannot go through postpartum depression. And that's something to really keep in mind because you already have a mom who's going through a very traumatic event. Um, and postpartum depression is linked oftentimes to hormones. And so we're sending her home with no baby. Um, and this is very likely to occur to some individuals. So it's good to keep that in mind. And then there are stigmas that surround perinatal loss that can complicate the grieving process for parents. And specifically, I'm talking about disenfranchised grief. And the reason that this occurs is because perinatal loss oftentimes is not socially recognized. These individuals feel like they really cannot acknowledge their grief to other people. Oftentimes, these families don't even have a funeral. Oftentimes, they don't even go home with a body because the hospital disposes of the fetus. Um, if the family chooses that route. Um, so they've been pregnant, everyone knows they're pregnant, and now they've lost a baby, and it's just, there's no funeral where they can outwardly grieve to people. There's no visitation where people can come by and see them. People don't stop by from church and bring food. It's a whole different kind of loss, and it can lead to complicated grief if it goes unresolved. Men and women oftentimes experience perinatal loss very differently. Women grieve much more openly. It takes them a longer time to get over the grief. They may have physical symptoms. So remember that I talked about postpartum depression. They may go through postpartum depression. Um, it's very individualized for women as well as men, and it can last from a few weeks to months or even years. I know people who are 80 years old who have lost children in utero and still cry when they talk about it. So for some people, it never goes away. Men have very intense emotions, and their response to perinatal loss is also very individualized, but most oftentimes men repress things. And even though they feel a deep sense of loss, they tend to grieve a little shorter in time frame than women do. And part of it, I believe, is because they have to be the comforter. The men repress their sense of grief, even though they feel that deep sense of loss, because they're comforting their wife or their significant other. but they do experience sadness and grieving changes over time. So, as the nurse, how can you appropriately communicate with a family who is going through a perinatal loss? Well, I've listed some things here. It's very appropriate to say that I am sorry. Um, it's appropriate to say some parents find that such and such is helpful. Would you like to try that? Um, it's very appropriate to recognize that they've had a baby, and you can say, your baby is beautiful. Do you see any family resemblance? And it's okay to say, this is not what you expected. I am so sorry. Um, we have to recognize what they're going through, and we have to acknowledge that they have that there is actually a human involved, and we cannot, as nurses, contribute to part of that disenfranchised grief that they may feel because it's not socially accepted elsewhere. Um, Inappropriate things to say definitely would be, it was not meant to be, it was for the best. So that might be something that might slip out of your mouth if you've had a family who's had a perinatal loss and the fetus was malformed, had the chromosomal abnormality. Don't ever say it was for the best to somebody, because to them, it was not for the best. You know, to them, they wanted it to be a normal, healthy baby. You're young and you can have another baby. That's not appropriate to say. Or over time, you'll forget your baby. Or when was the last time you felt your baby move? Um, Now, I want to say something about this last one. When was the last time you felt your baby move? This is a basic assessment question oftentimes when a mom comes in to the triage um, area. We want to know when the last time she felt her baby move. Because we might not know what's going on. That may be why she's there, because the baby has stopped moving. So that's a really important assessment question for the nurse to understand and know. And it's one the doctor is going to want to know whenever you call him to tell him what you have um, in triage. However, after there has been a perinatal loss, it has happened already. Um, this is really not an important question to ask, because it can come across as judgmental. So, be careful when you ask this question about the timing that you ask it and in the tone and the way in which you do ask it, so that it doesn't come across as being a judgmental question, um, so that the mom feels like what you're saying is, well, why didn't you come in earlier? So, what is helpful? We want to provide privacy at all times. We want to prepare the family before they see the baby. We want to have a supportive environment. We want silence, and we want to listen to them. We want to have the family view and touch the baby for as long as they want to. We want to encourage them to name the baby and take pictures of it, take a lock of its hair or footprints, and to save those. And oftentimes the nurse will actually do this piece for the family. And they may request the presence of some type of clergy, a pastor or a minister, and that's okay. It's your responsibility to get those people there. And it may not be something that they even think about, um, that they want to have at the time because they're so overrun with emotion. But as the nurse, it's your responsibility to ask, is there anybody I can call? Do you have a pastor? Or a priest that you would like me to get here. Um, you have to think about those types of things for them, because a lot of the times they don't think about them for themselves. So, back to the top one, providing privacy at all times. That means, give them a private room. Do not put them in a room with another mom who's just had a baby. Do your very best to keep them as far away from the rooms that have moms and newborns in them. It is very traumatic to have gone through a perinatal loss and then have to spend a night in the hospital, and you are right beside a mom who has just delivered a healthy baby that cries all night long. Um, it's heart-wrenching. So do your best to put them somewhere where it will be quiet and they won't hear all the babies crying that are on the floor. Here are a few nursing diagnoses that you can read through related to perinatal loss, and I just want to touch on a few of them. Um, Mostly the social diagnoses. Powerlessness related to fetal death. These people feel completely powerless because oftentimes they have tried to do everything right and it has not worked out to their benefit. So they feel very powerless in the whole process. If you can imagine being a mother who is carrying a living thing inside of you that moves all the time, and then you wake up one morning and realize that it's not moving anymore, and there is absolutely nothing you can do to save its life. That is a very um, terrible feeling to have, and it does make you feel extremely powerless. Um, let's talk about the compromised family coping diagnosis for a minute. Um, Perinatal loss is definitely a crisis, and we talked about families and developmental stages of families and how families have to um, have specific roles and functions and how those things will work together to move a family through the developmental process successfully. So you think about that family who is, or the couple who has decided to have children, and they are recognizing that their life is going to be different and they're getting ready to move into that stage of parents with an infant. Um, but then things don't work out that way. Um, they have to learn how to cope together, and they have to learn how to adjust their roles and functions to be able to cope with such a loss and move forward. So I want you guys to keep that in mind. So what do we want to happen if we are unfortunate enough to have to ever take care of someone who's had a perinatal loss? And if you go into labor and delivery, obstetrics, um, or even pediatrics, you will at some point in your career take care of a situation like this. So what we want to happen is we want the family to express their feelings. We want them to cry if they want to cry. We want them to talk about it if they want to talk about it, but we want them to be able to express their emotions freely. We want them to verbalize an understanding of the cause of death if we know what it is. Um, so if you know what the cause of death is, then it's okay to tell them that. Um, you know, if they ask you why did this happen, and it's because the baby had a blood clot in the umbilical cord, it's okay to tell them that. It helps them through the grieving process. We want the family to spend time to touch and to hold the baby, and it's important to allow them that time and to allow them all of the time that they want, because that also helps them move through the grieving process. And, as it occurs normally in society, usually when a loved one dies, you have time to have a funeral or a wake, you have time with them after they die in some form or fashion. But after these people leave the hospital, oftentimes they never get that opportunity. So keep that in mind. Um, the family will be able to recognize resources that will provide them with emotional support when they're discharged. And we want to make sure that they have that, even if it's the parents having each other, a support group that we know of, counselor. It's important for them to have some type of emotional support resources. And how does one perinatal death impact the future pregnancies, and how does it impact the family? Um, well, just think about that in general. If you're a mom who's had one perinatal death, and it was your first pregnancy, or even your second or third, and you subsequently become pregnant again, you can imagine how terrifying the entire process of pregnancy would be after having a perinatal loss. Um, it is very fearful for those people to go through another pregnancy because they are always worried about what if what if such and such happens, and that also has an impact on the family. So moving on to children's response to loss. Children's response to loss really depends on their developmental stage and their cognitive level. Children move through all kinds of developmental stages, and their responses to life events oftentimes are based on where they are developmentally and cognitively. Oftentimes, children have death anxiety. They are fearful about death and things that are associated with death. Um, and there are 4 tasks that children oftentimes go through for adapting to loss. They have to accept the loss and the permanence of it. They experience all kinds of emotions. They have to adjust to a daily life post that loss, and they have to recognize a change in the relationship with a lost individual in terms of memories and not daily continuing experiences. So, for example, if a child loses a grandparent, they have to recognize that there's a change in relationship there. Their grandparent, they will not no longer be going to uh, Sunday lunch with their grandparent every week. They will no longer see that grandparent in church every Sunday. Um, that relationship needs to turn from their thought of continuing experiences on a daily basis to um, memories instead. And so these 4 tasks have to be moved through successfully so that children don't experience complicated grief. So let's talk about loss based on age. Whenever we talk about ages 2 to 4, these kids are, um, you know, they're they're very immature in their developmental stages, and oftentimes their cognitive level, and so they cannot fully express how they feel or what their ideas are, especially associated with something as complicated as death. They see death as a temporary, reversible event. And they also get very messed up whenever you change their daily routine. We all know, especially those of us with children, that kids like a routine. They function best when they're on a routine. And experiencing a loss, especially a significant one for an individual who was involved in their daily life, it's a very hard for them to get used to that change in their daily routine. At this age level, you may see regression. You may see bedwetting. They may start sucking their thumb. Um, again, so it's important to remember that you may see those things, and it's a normal part of their response to loss. And they need more attention and affection. Um, again, they're fearful um, with things surrounding death, period. And now they've had a loss of someone that they know, possibly someone who is involved in their day-to-day life, and they're going to need more attention and more affection to help them grieve through that process. And this doesn't have to just be a person either. Whenever we're talking about responses to loss in regards to children, we can be talking about a family pet. Um, we can even be talking about things such as an abuser. Um, so, there are all kinds of things that children can experience in relationship to loss and grief. It does not always just have to be death of a person. So ages 5 to 7, at this age, they still see death as reversible, more than likely. They see that individual as still alive, but just in another place. So, for example, my 6-year-old asks a lot, is Peepaw still in heaven? So she sees heaven as a place that's away from here, and she knows that it's not on this earth, but she sees it as um, a whole nother place. And depending on who you are and what you believe, I guess it is. And that's how I explain it to her. But she sees him as still being alive in that other place. Oftentimes, 5 to 7-year-old age group have feelings of guilt surrounding death, especially if they've had some kind of um, argument with the person who was lost, or maybe they didn't clean their room up, or maybe they left the bicycle behind the car and that person ran over the bicycle and they got in trouble for that. Um, and then that person unfortunately experienced a death. Sometimes they will have feelings of guilt that it was their fault. This age also has magical thinking, and that can be associated also back with those feelings of guilt. So let's say, the kid didn't clean their room, and then their father got killed in a car accident. Well, they might magically think that because they didn't clean their room, then that's why their dad died. Um, these children also experience changes in their daily routine. So the same as for the 2 to 4-year-olds, um, they have changes in their sleeping habits and their eating habits, and they may even start to have nightmares. So it's important to know that so you can sort of help them through. They also may be fearful that other people close to them may die, and that may manifest itself in several ways. Um, they may have emotional breakdowns. They may be angry. Um, they may act out. And a lot of the times, the best way to get this age group to express their emotions is through artwork or play activities. So, what about 8 to 11-year-olds? At this age, these children have a better understanding of the concept of death. They sort of know a little more what it fully entails, what it means, and they're very curious about it. They also may have magical thinking, and like I said earlier, they may believe that something they did caused the death. They might exhibit aggressive behavior or acting out at home or in school. And this age group also may become very withdrawn. And then as we start to move up into adolescence and the teenage years from ages 12 through 18, these individuals really are more capable of understanding the abstractness of death. They don't think magically any longer, and their grief responses are very similar to adults. They can have a wide range of emotions. They can become depressed, but oftentimes they move through those Kubler-Ross stages. Oftentimes they will direct their anger towards their parents and towards authority figures, and they find solace in talking about their emotions with their peers. At this age, these children are really establishing their independence from their parents. They're trying to find out who they are, and they rely heavily on their peers for acceptance and self-worth. Um, so oftentimes they feel much more comfortable talking with their peers and end up expressing their anger towards their parents. So as a nurse, how do you assess grief in children and families? We initially have to assess the overall state and what happened. Um, it's important to know what their previous losses have been and how they dealt with those. We need to be really cognizant of the developmental stages of everyone that is involved in the assessment. We need to understand their family dynamics. We need to understand who their support system is. And we also need to understand their cultural and their spiritual needs, because they're very different um, for some people and for others. So we don't want to, as healthcare providers, to force our cultural and spiritual beliefs on our clients and their families, but instead we want to be supportive and nurture what their cultural and spiritual needs are. So that may take some serious communication to get down to the bottom of what those might be. Here are a few nursing diagnoses that you can go over in regards to children who experience loss. Fear is a good one here, because a lot of the times children are very fearful when they experience a loss. And death anxiety is another one. So if one person dies, they may have anxiety that another person is going to die. Here, think about the preschooler, the 2 to 4 year old and the 5 to 7 year old. Um, let's say they have experienced the death of a parent. Um, Oftentimes they become very needy, and they want a lot of that emotional um, attention and affection from whoever is left behind. So let's just say it's the other parent. Um, because part of that is that they experience death anxiety. They may cry when that parent leaves the house to go to work, because they become fearful that particular person will not make it back home. And it's important for us as nurses to be able to educate families in regards to these types of developmental issues when it comes to children, because it will help them to know what to expect once they go home. So what are some interventions that you can do? You can provide emotional support appropriate for that developmental age. So for those 5 to 7 year olds, you can provide some crayons or some dolls. You can play with them, have them do some artwork. We can involve family members in the grieving and the healing process if it's appropriate. We can provide cultural and spiritual resources that are appropriate. we can answer questions, we can be encouraging of an honest expression of their feelings and their emotions. We want to provide them with activities and outlets to help them release emotional tension in regards to their developmental stage, or provide support group information. So when we're providing activities and outlets, you really do have to base your intervention on their developmental stage. So like we said, for the 5 to 7 year olds, doing that artwork and play activities is very helpful, but that would not be helpful for that 12 to 18-year-old age group. It would be more helpful for that age group if you would allow their peers to visit if they were in the hospital. It would be helpful for you to encourage them to talk to their peers. And what do we expect at the end of all of this? We hope that the child can express their fears in relation to death and dying. We can hope that they acknowledge their grief and their emotions, and that they have a support system that's available and effective to help them move through the grieving process and do it successfully. And this is the end of individual module 3 on perinatal loss and children's response to loss under the concept of grief and loss.